Hello, and thank you for inviting me to talk today. Basically, my name is Dr. Tim Robinson. I am a clinical lead for NHS England long COVID for the Southwest region. I'm also a medical lead for BNSSG, the long COVID service for BNSSG. I was a GP for 30 years and have moved swiftly into the long COVID world. So, first of all, this talk is a overview of long COVID, and just to bring you all up to speed with the symptoms and how it's managed, how we diagnose it, and also the causes behind long COVID that are now sort of pretty widely accepted internationally. And then finally, what we do with our long COVID patients in the, certainly in the two clinics I'm the medical lead in. So first and foremost, what is long COVID? So basically, long COVID was defined by NICE back in sort of the end of 2020. And it's sort of broken down to the acute phase of COVID, basically from the onset of the illness to 4 weeks, that is acute COVID. And then long COVID is 4 weeks onwards. So patients who don't get better after the 4 weeks, after their acute COVID illness, then if their symptoms are persisting, they are sort of diagnosed and defined as long COVID. That is sort of further broken down into ongoing symptomatic COVID and post-COVID syndrome. Basically, 3 months onwards, you can be diagnosed with post-COVID syndrome. But essentially, long COVID is 4 weeks onwards. Just keep that in your minds. Also, keep in your mind that you don't have to have a positive test to be diagnosed with long COVID. But, however, it is really important, and this is made very clear in the NICE guidelines, that other causes for the symptoms have to be excluded. Once they're excluded, and they're more than 4 weeks, then the patient can be diagnosed with long COVID. People often ask just how common is long COVID? Basically, it depends on which study you look at. Again, there are lots of studies around the world, but basically between 10 and 20% of patients who have COVID have then persisting COVID, and then so 10 to 20% then developed long COVID. Next question we're always asked is, well, what are the risk factors and who can get it? Essentially, anyone can get long COVID. However, it is commoner in women, and certainly in the age group between 35 and 50. And it is commoner in patients who have other long-term conditions, such as diabetes, such as sort of chronic asthma or COPD. It's also commoner in patients who have a higher BMI. And finally, it is commoner in patients who have the sort of social deprivation. How does it present? Okay, so long COVID can present with a whole plethora of symptoms. There was a paper released in August 2020 in which 200 symptoms, there are 200 possible symptoms that one can then have with the diagnosis of long COVID. And that is across 10 different systems being the respiratory system, the cardiological system, neurological system, musculoskeletal system, the immune system, the hematological system. So 200 symptoms across 10 systems. And some patients may have 1 or 2, some patients may have 20, 30. Again, certainly in my experience in the 2 long COVID clinics that I work in, again, it is very rare for patients to have less than sort of 10, 20 of those symptoms. Of all of those symptoms, the big three, the commonest three, are fatigue, cognitive impairment, and breathlessness. Following on pretty closely, there are sort of a whole probably another 5-10 symptoms which are extremely common. So muscle pain, joint pain, headaches, sort of cough, loss of smell, loss of taste. You remember that for the acute COVID, that can persist. And then sort of anxiety, depression, those symptoms are certainly more prevalent in patients with long COVID. The other sort of characteristic of long COVID is the nature of it, in the sense that it seems to come and go. It's not a continual straight line trajectory. There are the sort of what we call the boom and bust phenomena, where patients sort of report an improvement, and then they sort of then overdo it, and then they bust. They then overdo it and run out of steam, run out of energy, have their symptoms returning. And we call this post-exertional malaise or post-exertional symptom exacerbation. So in long COVID, there is, as I say, this sort of fluctuating course. It is not a smooth, gradual sort of ongoing process. Our desperate patients are then obviously asking, well, okay, all right, I've got this diagnosis, but how long is it going to last? And, back in the day, back in the first year, we are now on the third year, just to remind you, we were saying, oh, well, it's going to be 12 months, it's going to be 18 months max. But hold on, we still have patients who 3 years on have their long COVID. So to answer the question, how long is it going to take? It's impossible to know. What is the outcome? Well, recovery, is the recovery, again, a patient's going to say, am I going to get completely better? Or is this what I'm left with? So basically, what are we seeing? What have we seen over these last 3 years in our long COVID clinics? We're basically seeing, we do see a significant number of patients who do get better. That is the good news. However, that's not everyone. That is the bad news. Recovery can be full. However, we do see increasing numbers, large numbers of patients who the recovery is, if you like, not complete. They're not 100%, maybe 80, 85%. Obviously difficult to put a number on it. We do see a group of patients who seemingly do get better 100% and then follow sort of a relapsing, remitting course where, if they overdo it, then they sort of, or they have another illness, or they have a coinciding viral illness. They can then sort of relapse, and then they recover again, but it takes longer to get better than it used to before they had their long COVID. This overall thinking prognosis, I think we have to draw from, because it is charting sort of new territory, but basically I think we have to draw from other research and look at other pandemics in the past. This current long COVID pandemic is as a consequence of SARS-CoV-2. Okay. So there was SARS-CoV-1, or it's actually just called SARS-CoV. So the sudden, severe acute respiratory syndrome illness back in 2003. There was a study that shows that at 4 years, this is the Hong Kong study, at 4 years, 40% of those patients still have fatigue. What's more, 30% of those patients could be diagnosed on the Canadian and also the international American criteria for ME/CFS. More on that a little later. But also other pandemics from MERS, the Middle Eastern Respiratory Syndrome pandemic back in 2012, Ebola. In patients who had those illnesses, there are studies to show that significant numbers of those still have the after effects, ongoing residual effects of their original illness. So, you know, therefore we can draw from that, and we can actually say that actually it's probably pretty likely that following on from SARS-CoV-2, the COVID pandemic, we're going to have patients who still have ongoing symptomatology. So how do we manage it? What are we doing in our post-COVID clinics? So basically, it all comes down to looking at the patient and sort of taking into consideration the underlying problems. Before I go into the actual sort of nitty-gritty and nuts and bolts of the management, let's remind ourselves of what we know about long COVID with regard to the causes. So there are a number of causes. When the whole pandemic kicked off, we initially thought this is going to be a respiratory illness because it is a coronavirus is a respiratory virus. There are a number of coronaviruses that cause pretty harmless upper respiratory tract illnesses. There are others, the rhinoviruses, the adenoviruses, can cause, as I say, pretty harmless respiratory illnesses. But unfortunately, this particular form of the coronavirus, SARS-CoV-2, because of its spike protein being on the surface of the virus, is particularly harmful because that spike protein links up with the ACE2 receptors, angiotensin converting enzyme 2 receptors, that are expressed in more or less all cells in the body, but in particular the cells lining the blood vessels all through the body. So consequently, wherever the virus goes, it then links into those receptors all around the body. So therefore, those blood vessels that serve any particular tissues are going to have those tissues affected. So consequently, if we think systematically, so the cardiovascular system, so then that the respiratory system, neurological system, so the inflammation and the response to that attack can be felt. And we now know that the response as a consequence of that attack leads to a dysregulation of the inflammatory system. We've all heard of cytokine storm. So overactivity of the pro-inflammatory reaction to fight the infection. Unfortunately, the overreaction leads to these release of these cytokines, which then attack normal tissues. Not only that, the inflammatory system overacts with regard to the blood coagulation system. So it makes the blood sticky and it lays down very fibrin tissues. And we've all heard of the microthrombi problems that result as a result of this excessive sticky blood. well as that, the inflammatory system overacts and then triggers release of mast cells. Okay, mast cells also contain lots of inflammatory mediators, but particularly histamine. So lots of our patients have histamine-like type reactions. Another consequence of the actual underlying attack is the dysregulation of the immune system. So that sets up overactivity of the immune system, resulting in the immune system attacking ourselves, the autoimmune phenomena, autoantibodies to any of the cells throughout the body. And then there's the direct effect of the virus itself on the body. Another consequence is dysautonomia, so dysfunction of the autonomic nervous system. So then that can cause any number of problems within the brain, and such as blood pressure problems, racing pulse, and difficulties with temperature regulation and dysregulated pain responses. So all that is happening and resulting in damage of the whole body, throughout the body, different organs and different tissues throughout the body. So therefore, as a consequence of all those different those effects on different systems, it does lead to different symptoms. And the symptoms, as I've said, anything up to 200 different symptoms across 10 of the different systems. So because everyone is an individual, everyone is different, and the virus affects the individual in different ways, then every individual is going to have different set of symptoms. And it is incumbent on us in the post-COVID services to try and sort of thrash out the underlying main symptoms to be able to advise, support, and guide on. So essentially, management of long COVID is an individualized care. So it's tailor-made, it's fitted, the care delivered is tailored to the patient and what the patient is experiencing. So it's not one size fits all. Like diabetes is one size fits all. There are just a number of treatments and there are a number of symptoms. Or COPD, likewise. Because of this, there's no quick fix. As I've said, it's unpredictable. There's no magic bullet. Unfortunately, this does lead to, if you like, impatience, because it takes forever. It seems, despite, doing all the things that we are guiding our patients in the post-COVID services, patients, despair, understandably, and so they turn to sort of the web, social media for supplements and therapies, etc., which many of which are not evidence-based, some of which quite frankly, I think are unsafe. And you can understand why, as I say, because it's taking so long, but actually this can confuse the picture and, leads to worsening of and makes it all a lot more complex. So in a way, a lot of what we've got to do is to actually try and be patient and, and go with what we are providing in the long COVID services. Patient, because, we've learned a lot through the years, but the 3 years has been international research like there's no tomorrow. There are 30,000 papers on long COVID alone, 300,000 patients on papers and trials on COVID, 30,000 papers on long COVID. So we've learned a lot more, but there's no quick fix. And as I've described, it's no single fix. We need a blend of measures specific to those symptoms. And it may take years. You know, and it may take sort of a change in outlook and jobs, and you know, but I think it's important to accept that, you know, you've been unlucky to have COVID that has then progressed onto long COVID. And I think what we've got to do is try and accept that and work with the services. So what are the post-COVID services, long COVID services? What are we providing? So the sequence is that a stepwise sequence, really. I think it really starts at the beginning. Basically, if someone has what they think is long COVID, it's a matter of going along to the GP, who will hear the story, do the examination, do investigations. Like I said at the start, you know, you can diagnose long COVID as long as you've excluded all those other symptoms, excluded other causes for the symptoms. You know, so tiredness is not because of hypothyroidism, underactive thyroid. That has to be excluded. Or anemia, for example. I saw a patient, I'm just dealing with a patient at the moment, who's presented, and actually, lo and behold, they are anemic. So part of the fatigue of that patient may be because of anemia. So those treatable, normal conventional diagnoses have to be excluded before making the diagnosis. So that is the realm of general practice and primary care. Going on from that, if we have excluded it, it's a matter of the GP referring the patient to the long COVID, post-COVID service, where their case is assessed by a case assessor, and more often than not, a allied health professional. And that patient is either, it's quite straightforward and quite simple, and the patient is managed with advice and guidance, or the patient may be more complex and is brought to the multidisciplinary team meeting, where we meet on a weekly basis, all the allied health professionals, doctors, so physiotherapists and occupational therapists, speech and language therapists, mental health service, all part of that team. And that is so important, because everyone sees the patient slightly differently and everyone can contribute and put their view in. We need the occupational therapists to guide us on managing fatigue and vocational rehabilitation. We need the physiotherapists to guide us on respiratory, the breathlessness aspects and the cough aspects. We need physiotherapists to guide us on the musculoskeletal aspects. So those patients who have the painful joints, painful muscles, but also those patients who, because they've been unwell, they're sort of slightly deconditioned. Their condition is suboptimal. Speech and language for swallow and voice problems, mental health service. Or, why are they in there? Really, because of the impact long COVID has had on the patient. And obviously, if any of us had long COVID, or, any of us had an illness that is just going on and on and on, we naturally fear, when am I going to, and ask the questions, when am I going to get better? Maybe I'm not going to get better. And, and then the fact that the knock-on effects on the dynamics on the family and your self-esteem and of course vocation, how am I going to pay my mortgage if I can't work? Am I going to lose my job? Am I going to lose my house? I mean, there are patients who have lost their house, lost their job because of this. So, consequently, that gets you down. And so it is hardly surprising. You get anxious, you can get depressed. So that's why mental health services are an integral part of our MDT, our multidisciplinary team. So those services all offer their area of expertise with addressing those features of long COVID. But the post-COVID service can also signpost and refer to sort of Your COVID Recovery, the NHS website for long COVID, Key Active, Managing Fatigue, Hope program, which is an excellent program, which I do a Q&A, question and answers for, to patients, just on one the other day. And other, it can be signposted to Vitamines or health and well-being services. But I think more importantly than, or equally more, is that there is an ongoing link for those patients with long COVID with the service. It's not a case of seen, signposted, discharged. No, there's an ongoing buddying process, if you like, between the service, the most appropriate, remembering individualized, most appropriate allied health professional, and the patient ongoing. There will reach a stage when the two of the patient and the practitioner will come to the realization, I think we've done what we can, so on you go now. We'll put you on a patient-initiated follow-up plan, and that is, we won't contact you, but you can contact us anytime now for the next 6 months, say, if you should want. So the patient does not feel like they're being discarded, discharged, discarded, never to be seen again. No. So I think that's really important for us to be able to tell the patients that that's what is happening. So those are, I think all the sort of the main features of what occurs in the post-COVID service. And I think the post-COVID service also takes a more holistic view as well, and sort of advises on diet and sort of lifestyle, and sort of gives a sort of an overview picture, which I think is very important. So I really, in a way, that's sort of, it's a whistle-stop tour of long COVID. And, I think that, there's a lot of information that I've imparted, and I hope that, it's been sort of clearly put over and given you a sort of a overview picture of what it's all about, and where we're going, and the trajectories, and what can be achieved and what can be provided by the post-COVID services. So in a way, it brings me to the summary, and that is, long COVID, it is a new condition. It's only over the last 3 years that we have been trying to deal with ongoing COVID symptoms. It is a complex, multi-system, multi-symptom, multi-causal condition. I call it is the perfect storm. That is a fact. Long COVID is not fully understood. As I said earlier, there's been a ton of research worldwide, and we do know a lot more than we did. That is a fact, but we don't know it all. It's a complex condition, so therefore, and multi-causal, so therefore it's obvious there's not going to be one single treatment, one bullet, one supplement, one thing on the web, one sort of treatment that is going to deal with it. That is a fact. And I think the final fact is that, we do not know how long it's going to last. We don't know what the final outcome is going to be. We've got to draw from previous experience, but it is unpredictable and it is unknown. That is a fact. However, what we do know is that we are seeing patients improving in our post-COVID services, definitely. There is improvement will occur through natural recovery, and natural recovery, what is that all about? That's all to do with rebalancing of all the body systems, letting everything calm down and repair. letting the inflammation calm down, the immune system calm down, endocrine system, neurological system, all the systems calm down, along with natural tissue repair, sort of cellular healing. That takes time. We've got to give it time for those natural healing processes to work. It really is long COVID. As I say, damage has happened with long COVID, with COVID, and then consequently long COVID. It is a physical thing. It is not, as unfortunately and mistakenly, a lot of the general public, employers think it's all in the head. No, it is not all in the head. It is not imagined. It is physical. So consequently, I think it's so important that, you know, we keep reinforcing this to those skeptics who feel that, you know, people are wasting time or there's nothing to show for it. It's not like a broken leg. It is not all in the head. It is a physical thing. And so consequently, we need all this input, in particular with the vocational side, because of the effect on not being able to work. So there we are. I hope that's been informative, and I hope that I've not given you information overload, but that in a nutshell is what long COVID is all about at the moment. Over to you.
Thank you, Tim.